Hey, good morning. Are we good to go, Lila and Margaret?
Yes, we're good to go.
Okay, well, good morning. It's my pleasure to welcome you all to the first ever virtual research day of the Department of Psychiatry. This, of course, would not have been possible without the leadership of Professor Sophia Frangu, who's the Associate Head for Research for the department, and also our co-leads for research, Dr. Tim Murphy and also Dr. Trisha Chakrabarty, and many of our staff, including Margaret Koshi. Now, as you all know, this has been an incredibly challenging year. The pandemic has affected not only the functioning of the department and our professional lives, but also our social lives. But thanks to the resilience shown by all of our faculty, trainees, and our staff, we have adapted, and the department has resumed a number of activities despite the ongoing pandemic. We've resumed a number of educational activities and research activities. We've also completed the strategic plan for the department for the next 5 years. And we've also completed the process for the Marshall Scholar and Fellowship Program, and the program has received this year a record number of applicants, and that process, as I said, was completed recently, and all the winners have been notified. Importantly, the department has attracted $14 million in terms of research funding in the last fiscal year, which is $4 million more than the average for the department, because usually we get about $10 million, and in the last 12 months, we got $14 million. And I think all of this clearly speaks to incredible quality of research that's happening within the department. And so, although we had initially considered not holding a research day this year because we couldn't have an in-person event, but we decided to go ahead with the virtual research day because we wanted to have an opportunity for all of us to share the research that's been going on within the department. And as I said, our associate head, Sophia, and Tim and Trisha have put together an excellent program for the day, and we have a number of our senior and junior faculty giving presentations, in addition to many of our outstanding trainees. We also even have a symposium on COVID, because obviously we couldn't have a research day without talking about COVID, and a number of faculty members within our department have taken leadership role, both in terms of research and also education, as well as in providing clinical care for supporting people that have been affected by COVID in terms of mental health concerns. But I'll let Sophia to tell you more about the program. Enjoy the rest of the day, and thanks very much for joining. I'll turn this on to you, Sophia, now.
Thank you. So, as Lakshmi said, we are very pleased that we have put together this virtual research day, and I would like to reiterate my thanks to Margaret Koshi, Amity Chiang, Leela Berry, and Vicky Yao, who worked extremely hard behind the scenes to make this possible. Also, many thanks to Tim Murphy and Trisha Chakrabarty for the work that we did together in order to put the program that we hope will appeal to both clinicians and researchers. So I will briefly go over the program just to give you an idea. So it will run from about sort of now to 3 o'clock. And in the morning, we have a session before and after the coffee break at about 10:15. We start with a talk by Professor Michalak, and then this is followed by the first set of lighting talks, which are very brief talks highlighting research done mostly by junior faculty. After that, we will proceed to, we have our break, as I said, and then we will proceed with the second set of lighting talks, followed by a presentation by Dr. Panenka. After that, we break for an hour between 12 and 1. During that hour, we would very much like you to visit the poster gallery. You have seen the link, and it's also available through the departmental website. There are, we received a record number of posters, one better than the other really, which shows the vibrancy of the department and the commitment of people to continue research despite COVID. So we have pre-selected some posters that we thought were particularly outstanding, and it would be really great if you use Slido to vote for your preference with regards to these posters. At the same time, you can use exactly the same function, but in order to indicate your preference for the lightning talks, because at the end of the research day, we will announce the winners both for the posters and for the lightning talk speakers. So at 1, we return back to listen to Dr. Chakrabarty presenting a talk on virtual reality in mental health, and this is followed by our special COVID session, where we have 3 fantastic presentations talking about the psychology of COVID-19, the impact that it has had on the mental health on the campus, and I think crucially the way that our clinical teams have responded to this challenge. And we will hear from 2 of our clinicians that are leading the COVID-19 clinic and trying to meet the needs of the COVID-19 survivors. They will tell us both about the clinic, but also I think something that would probably be of general interest to most of you about the clinical presentation of the individuals that we have seen. And after that, we will announce the awards, and that would be the end of the research day. I wonder if Tim or Tricia would like to say a few words before we start more formally with the program.
I guess I could just say hello to everyone, and thanks to all on the team for putting this together. And I guess I just also like to remind people to click on the tab called Polls in Slido. I guess those will go up later during the lightning talks and the posters.
Excellent. Tricia, would you like to say hello as well?
Yes, hello everyone, and welcome to our research day. Thank you so much for joining. And just in addition to thanks to the whole team, I just really wanted to thank the trainees and junior faculty who submitted their abstracts and were game to try this new format, and also our speakers. So I hope everyone enjoys the day and finds it useful.
Great. So since it's our first time for doing this, we hope that everything will go smoothly. Can we see if we have Erin's slides available before I introduce her?
Sophia, you may want to turn your camera on when you speak.
Okay. Hi. But I still can see the slides. Are they up?
Margaret, Lila, who has got the control of slides? Can you put up Erin's slides? Share the screen. There we go. Oh.
Yep. Erin will put up her slides.
Yeah.
Erin, just let me know when you're ready.
I am ready.
You're ready. Excellent. Fantastic. So it is my absolute pleasure to introduce the first speaker, Professor Erin Michalak, who is internationally recognized as a researcher in bipolar disorder. She's the founder and lead of CREST-BD, a CHR-funded Canadian network that is dedicated to collaborative research and knowledge exchange in bipolar disorder. She is one of the key opinion leaders when it comes to patient and public engagement in mental health. And in addition to the many distinctions that she has received, as well as the funding that she has received to support her work, I would like to highlight two major and very recent awards. In 2018, she received the Gold Leaf Prize for Transformation in Patient Engagement, which is Canada's most prestigious recognition for patient engagement in research across all health disciplines. And last year, she was also awarded the Douglas Arting Prize for significant accomplishments in promoting awareness and treatment of depression in Canada. So we are in for a treat, and I will give the floor to Erin.
Thank you so much, Sophia, and good morning, everybody. I just want to acknowledge that I'm joining you today from Huesam, which is the traditional name for Roberts Creek. It's a small village on the Sunshine Coast where I live. I'm going to start with a little bit of Shakespeare, because who doesn't like a bit of bard first thing in the morning at the beginning of a virtual meeting? This is a quote taken from The Tempest. And it's actually a song that Ariel sings to Ferdinand. We're not sure historically whether Ariel was, Shakespeare described him as a man a couple of times in the play, but he's been played by women and men over the years. But he's definitely, or they are definitely, a bit of a kind of monkey kind of a nymph that used to get into a lot of trouble and sort of tell a bunch of lies. In this particular one, they sing to Ferdinand this quote: "Full fathom 5, thy father lies, of his bones a coral made. Those are pearls that were his eyes, nothing of him that doth fade, but doth suffer a sea change into something rich and strange." And this idea of a sea change is kind of the guiding metaphor for my time with you this morning. In modern use, a sea change refers to a paradigm shift or a changing zeitgeist, often at the level of society where opinions have changed strongly in another direction. And I'll be questioning at the end of this talk and kind of reflecting a little bit if we are at that point currently in terms of how we view the value and importance of patient engagement, of the engagement of people with lived experience of health conditions in research processes. I've got 4 objectives for today. I'm going to start with a little bit of introduction to how we view the spectrum of patient engagement in health research. I'm going to give you a high-level introduction to our network, CREST-BD, and some concrete examples of methodological approaches, deeper dive into that from our research over the last 15 years or so, and then end with some time for reflections and questions at the end. Now, if you start to Google patient engagement, let me start a little bit with the language around this. My preferred term in CREST-BD is lived experience. We term the people who live with bipolar disorder in our network peer researchers, but you're going to find a whole bunch of different language in this area. Patient engagement is the language that we've inherited through the strategy for patient-oriented research from CIHR. Service user involvement would be the key phrase in the UK. So I'll be sort of interchangeably using this language throughout this talk. But all that being said, if you Google patient engagement, lived experience, inclusion in research, you're going to find a lot of similar kind of constructs and sort of organizing diagrams and frameworks. This first one conceptualizes and visualizes community-based participatory research. So in CREST-PD, we've also always described ourselves as a network that specializes in community-based participatory research. And the way that's viewed is often on a spectrum from traditional or classic research, where we have research participants. Classically, we would have called them subjects, but research participants who are barely, if at all, involved in the research process itself. Moving on from that, we can look at different levels of engagement whereby people get some opportunity to partake in thinking about the questions that are being asked by science, the methods being developed to do the science, and getting involved in the knowledge translation and knowledge exchange activities at the end of that. CPPR is kind of like the hardcore end of patient engagement. Participatory action and research would be another model there. And that's really seen by many as an opportunity for communities to drive research and often be actually in charge of the research itself and its direction. This is an image that we created for the BC Support Unit here in British Columbia, which is a wonderful group supporting patient-oriented research, if you're not familiar with them. And again, it shows this same cycle of engagement from the inception of the idea to helping it flourish and grow through to harvesting the results. And then if you look at some of the activities that are related to sort of SPORE and the networks associated with that, we see similar representations running from consultation to involvement to collaboration to really patient-directed and steered research. And I'll just leave this image with you, which clearly positions that patient engagement means research led by the public. So let me walk on to give you a bit of an introduction to CREST at a very high level. We are, at this point, an international network spanning several countries. We've always valued interdisciplinary expertise, so we're not just sort of residing within psychiatry, but we cross occupational therapy, social work, psychology, and a range of interdisciplinary disciplines. But core to our mandate and our work has always been that we value all and diverse types of expertise equally, including the expertise of frontline healthcare providers and clinicians, with the sort of centralizing ethos that we think we can do research differently by working in the spaces in between those types of often marginalized expertise historically. Let me show you how we were funded, just for a slightly different lens. It's kind of an interesting kind of historical look, I think, also at the Canadian funding system over the last sort of 15 years or so. We were first supported through a Michael Smith Teen Startup Award. This is a very small award that was meant to kind of galvanize small research teams to come together. Very important funding for us at that point in time. And it allowed us to do some initial priority setting work, to work with clinicians and people with bipolar disorders, talk to them about what their priorities for research are and what our priorities in CREST-BD should be. We settled on kind of 4 central areas: the study of quality of life in bipolar disorder, self-management and self-care strategies, stigma, and psychosocial treatments and psychosocial interventions. It gave us just a year of funding at that point. And then in 2010, we secured our first major piece of funding from CIHR, from the Canadian Institutes of Health Research, which was a 3-year network catalyst grant. And that really allowed us to move from a provincially focused team through to a national network, which was pan-Canadian. Not too long after that, we received our first 2 kind of operating grants. One was a Catalyst grant focused on digital tools and digital interventions for bipolar disorder, which was 1 year, and then a 2-year Knowledge to Action grant. At that time, we were seeing a lot of funding through CIHR for knowledge translation. We don't see that in its sort of previous guise as much anymore, but a lot of our initial funding came for KT research. And then, as mentioned by Sophia kindly at the beginning of this, in 2018, we were awarded, I don't see this as an award for me, I never have. We very much see it as, you know, a recognition of the work that we do collaboratively as a team in CREST-PD. But we were incredibly honored to receive the Goldley Prize for Transformation from CIHR. And then in 2019, we got our next major project grant, which is we're in the thick of now, 3 years of funding to advance our prior work. I'm going to go back for a moment, though, because I'm going to show there's something I wanted to point out in this slide set, because it looks very rosy and smooth at this level. But if I take you back in this chronologically, I'll just point out to you that with the end of our Knowledge to Action grant in 2013, so in 2015 we wrapped up that piece of funding, there's a noticeable gap there in between the funding that we received for that grant and the end of it and our next major operating grant. This wasn't unique to us. Many of you who are academic researchers or hold funding in Canada and beyond would have been in difficulties during those years. There were a couple of, frankly, there were a couple of mistakes that I made. I put all of my eggs into a new funding opportunity that was being offered through the government for programmatic funding, but I wasn't putting my energies into the other types of traditional funding and operating grants that were available. So there were some poor decisions or pure lack of time on my part to do what you really are encouraged and need to do sometimes, which is, you know, apply for everything that's available. But beyond that as well, funding was just so lean and so hard during those years. It was remarkably difficult for many of us to keep our research groups going during those tough times. We did keep going, and on it's not even on a surface level, on a very real level. We produced a number of major outputs during that time. We participated and collaborated on many international studies. We continued to do our knowledge exchange and translation work and run events, keep our websites and social media functioning and active. But it was really, really frankly, very difficult and hard. And when I look back in time and think about the factors for success or what helped us during that time, there were a couple of things, one of which was philanthropic and charity support. We received funding at that time from a local organization, the Laurel Foundation, which really helped us stay afloat. And I really want to emphasize the importance of philanthropists in helping in lean times and beyond lean times in science. It was key for us. Another thing that was key was partnership with other organizations. So our partnership, for example, with CanMat, with other groups that were working in different areas but with similar goals to us, like Heads Up Guys, which is under the steership of John Lagroshenchuk in our department. Working with groups like that through these difficult periods was tremendously helpful for us all, I think. And then beyond that, I really do believe that the one thing that kept us afloat was the passion, dedication, and commitment of the peer researchers, of the people with lived experience that were engaged in our work. They cared as much as the academics and the funded researchers in the group, excuse me, about survival. And if it hadn't been for that dedication of all of the people working around the fringes of this, frankly, we wouldn't have made it to this point of time. So I just wanted to kind of, you know, take a pause about the reality of funding for us all sometimes, but also the importance of public involvement and patient involvement in that process, and how it can really support sustainability. Okay, so let's take a bit of a deeper dive into some of the methods that we've used. For these slides, I'm going to focus on our program of research into quality of life and self-management, and that's really kind of been complemented over the years by a strong move into digital health innovations and online work and app-based work. So way back when, in 2010, we developed the world's first specific scale for people with bipolar disorder to assess quality of life. Very recently, Emma Morton, who is our fabulous postdoc in the group here at UBC, who was brought here from Australia a year ago with a Marshall Scholar Award, actually reviewed the use of this scale over the last decade since it was published, and it's great. It's being used internationally across a number of different trials and study contexts. So seeing nice uptake in terms of its paper and pencil version. But we very swiftly realized after publishing it that paper and pencil versions of assessment scales and measurements are not very useful in routine clinical practice or in the hands of the daily lives of people with mental health conditions. So we needed to develop a web-based version of it, an online version of it. And you'll see a lot of familiar faces from our department as we go through this set of slides. But this is just to illustrate at that time how we were beginning to co-design new tools with people with bipolar disorder and clinicians. We often do live face-to-face events, so we held a one-day event to think about how the quality of life tool should look. We always use mixed methods during these events and try and harness the power of those different methods, and also to yield as much as we can for more traditionally privileged outputs like publications, future funding applications. And so that diverse use of methods has always been very helpful to us in patient engagement research. For this one, we did formal focus groups, we did user-centered design methods, and graphic facilitation and recording. So group discussions, those focus groups, and then prototype co-design. So we worked with our IT company before we got into this event and had them mock up some ideas of what a quality of life tool would look like, and then worked with people during the event to consult on our initial ideas. These are what some of those ideas looked like. They basically mostly just tore our ideas apart and went back to the drawing board with them. They hated this one. They said it looked like anacrid and spider-like. They didn't want to see bar charts or line charts or anything that was very medicalized. Instead, they were prioritizing a much more kind of holistic representation of quality of life, surprise, surprise. And this is what they came up with, which we took back to the IT company and our core team to develop the quality of life tool, which has been functioning for quite some time now and is fairly well published on. And you can see what that looks like in terms of the way it's laid out for users with bipolar disorder to complete. Okay, so this is great. We had our paper and pencil quality of life scale. We had an online version to complete quality of life scoring, but we didn't have any way to tell people about what they could do for self-management or self-care strategies if they found that they were not functioning as well as they wanted to in certain quality of life domains. So in tandem with that work, we developed the Bipolar Wellness Center, again with CIHR funding, to provide a one-stop shop for people with bipolar disorder, and then there's also a clinician or healthcare provider section of this, for the most evidence-informed information we can provide on self-care strategies that we believe work for bipolar disorder. And this is organized around the same domains that the QoL-BD, that the quality of life scale is. So, for example, if somebody saw that they were scoring poorly in the cognition life area, you can segue into a section of the Bipolar Wellness Center that gives you good resources and tools to support cognition specifically. Shout out to Ivan Torres, who really helped us populate this area. And then on top of that, we tested out different knowledge translation strategies. So we said, okay, well, that's great. You've got a website, you've got all the information there, but how do you actually help people with bipolar disorder to best access and utilize that information? And we tested out 4 different types of KT, knowledge translation strategies. First of all, fairly short webinars, which were focused on a specific domain of interest. Know that several of those webinars were delivered by people with lived experience of bipolar disorder. They weren't all just delivered by academics or scientists. We then produced a series of videos. These were short, very much focused on pragmatic self-management strategies. They all featured Victoria Maxwell, who's a fabulous mental health educator who herself lives well with bipolar disorder. So that was those. And then workshops. We actually toured a workshop focusing on sleep and mood and bipolar disorder around Ontario in collaboration with the Mood Disorders Society of Ontario over there. And those were delivered as well by people with lived experience of bipolar disorder, clinicians and academic team members, and they were sort of deeper dive into those two domains of interest. And then finally, we tested something that we called a living library, which was an opportunity for people with bipolar disorder to be paired up with a CREST BD peer researcher, somebody living with BD, to review their quality of life scores and then to have a tour around the Bipolar Wellness Center to think about different areas of self-management and self-care and to kind of contextualize them in their real life. So basically, we were looking both quantitatively and qualitatively at the impact of these 4 types of intervention as knowledge sharing sort of devices or routes. Dr. Emma Morton produced some very nice papers on this work that I'd encourage you to look at if you're interested in learning more. This was the primary result paper published in JMIR, and we found some really interesting and very useful results to guide our future work in this area. In particular, we found, as you can see on the right-hand side, that the more static interventions, that is the webinars and the videos, actually were had a negative, a deleterious effect on sort of self-efficacy and empowerment in the sample compared to the elements that had more human interaction, that is the workshops and the living library. So very useful pilot data for us to continue on to our next funding application to CIHR. And when we stopped and paused at that point, having done that body of work into quality of life and self-management, we were acutely aware of the fact that there are some really, first of all, there were some limitations in our research, but there are some pretty significant limitations in the field of digital mental health more broadly. In terms of our program of research, all of our applications were web-based, and clearly a lot of people are using apps now, so it seems very necessary for us to move into that app realm. But when you actually look at the wider evidence base for mental health apps, if you're working with people with bipolar disorder, you can download one of over 10,000 apps currently. You can hold in 2 hands the number of apps that actually have a good evidence base for them at this point. Some of them are actually quite dangerous and provide recommendations that are clearly not aligned with what we would recommend from academic evidence or from clinical expertise or guidelines. Our data is sold a lot of the time without us realizing it. We're not doing a good enough job of ensuring privacy for people or clearly explaining to them what privacy means in a way that's palatable. That needs to change. And many of the pieces of health data that we're producing are not interconnected. So think about if you're using any apps yourself, often if you're using an exercise app and say an app for your mood, you're not able to look at the relationship between exercise and mood. They exist as islands of health data, and they're not optimized for interconnectivity. And critically for us, we're not building apps and health interventions online with diversity in mind for racially diverse, different ethnocultural groups, people of different gender identities, and really importantly for the people who face the most barriers to care and to access of mental health services. So that needs to change too. So this was part of the rationale that we made for our second piece of funding, or our next piece of funding for our Bipolar Bridges project, which we're in the middle of now. And it is designed to try and tackle some of these outstanding field problems. We want to create an app-based system where people can combine and learn from different types of health information all in one place. We want the system to be very secure and safe and to put users, people with bipolar disorder, in control of their own health data and how that gets shared. It will be designed, is being designed with a very heavy focus on equity, diversity, and inclusion by design. And I'll talk about some of the processes that we're using to do that in a minute. And then critically, it's going to have the potential, we hope, to begin to predict quality of life through machine learning or AI approaches, and critically to be able to provide some tailored recommendations to people with bipolar disorder on the basis of other people's data over time around self-care or self-management strategies that might be useful for them specifically. And so we've advanced our methods for patient engagement at this point, although some of the key elements are the same. We do face-to-face meetings, a lot of whiteboarding, a lot of visual work, a lot of graphic work. We have, for the first time, actually established a specific project team for this project. So since the inception of CREST-BD, we've held a community advisory group, which meets every 3 months and advises on all of our projects. But for Bipolar Bridges, it now has an 8-member team of people with bipolar disorder who guide this project specifically. And we meet quite frequently, once a month or so. And we've developed a partnership with Maslow, which is a US-based company with some real sort of potential in AI. They've been a wonderful technology partner, industry partner for us to work with. And we're deep into the stages of creating the interface for people with bipolar disorder to use the system, and in a way that's built for engagement. You know, one of our core things that came up in one of our meetings this week is the idea of really needing to drive the science around what keeps people engaging with apps, because most people don't, right? They download them and never use them, or they use them a couple of times and never get back to them. This is a perennial problem in this space and one that needs to be addressed. It's a little bit more of, this is Maslow's work, not ours, but we'll be working kind of partly within this visual framework. And so to complement that work, we've also been doing a whole bunch of other pieces of the study. For example, we wanted to do a survey online internationally to find out what apps people are using with bipolar disorder currently and what their clinicians are recommending to them. This was at the point of a couple of months into the study in June of this year. And yeah, the numbers were going okay. We recruited just under a couple of hundred people internationally. But we weren't happy with the data that we were getting in terms of its diversity. The majority of them were white. There wasn't much international representation in the survey. The numbers that we were getting for trans and gender non-binary weren't where we wanted them to be. So we went through a number of processes to really try and open out diversity, open out engagement with this online survey, hand in hand with our community advisory group, our Bipolar Bridges advisory group, and a number of other techniques, including a little bit of social media advertising. And this is what happened. Just 20 days after that point, we'd recruited over 1,000 people from 64 countries. Critically, as part of that drive into an international space and beyond just the boundaries of Canada, frankly, we really managed to increase our ethnicity diversity within the sample. It's a real nice example of, I think, how patient engagement really helped us with the quality of the science that we were doing and our reach into communities that are very valuable to us. So that's the end of that piece. I just wanted to mention, sort of before I close for questions, that heavy patient engagement in CREST-BD has also given us the opportunity to be quite nimble in our response to world events. COVID is the example of that. Because we had these structures in place, we were able very quickly, before the end of March of this year, to deliver the first of a series of COVID-focused webinars. They're not static webinars. They're designed to be very interactive and friendly. They're called Talk BD Live. They're held about every month, and we've received some funding support to continue to do these for as long as needed. I don't know how long that will be any more than you do at this point. But this has been a really important output for us, for our community, in a way that we can support them with what they need right now. And then finally, I only focus on our quality of life studies, but we use very different approaches for other studies within our program of research. This is another one that we've just launched in collaboration with the Band Lab down in the Bay Area, looking at psilocybin use in bipolar disorder. It's important to know that blogging for us has been a really important way for us to reach communities. And we've also learned there's a huge appetite for work in this area. This particular blog kind of is talking about launching the study is, and has been for some months, the most searched thing on the internet around the relationship between bipolar disorder and magic mushroom or psilocybin use for therapeutic purposes. Okay, so just a minute or so on reflections, and then there'll be a little bit of time, I think, for questions. Strategically, we know it's important in the Department of Psychiatry, the Faculty of Medicine, at UBC, for us to be including patients, the public, community in the work that we do. It's, in our experience, been incredibly valuable for us to improve the quality of the science that we're doing, and I hope that I've given you a few examples of that as I've trotted through this. But I'm going to come back around to where we started with this talk. Remember those diagrams, those examples of the spectrum of engagement. And I think one of the things I wanted to mention, particularly perhaps for the more junior researchers who are on the line for this talk today, is that I think that can be a bit intimidating for people when they start their first forays or start to think about how they might include patients in their research. It doesn't need to start like that. A little bit of patient engagement in research done well is better than going in my opinion, at the deep end with fulsome engagement when you don't necessarily have the capacity or the expertise, or you haven't built out these systems for your particular program of research or research project to support that. So first of all, don't think that it needs to occur at that level. Think about maybe discrete points of your research project or program that could be really useful. And you can grow if you feel like this is an area for you into that area and build capacity for that over time. I think when we reflect back on CREST over sort of the last 10 or 15 years, it's just helped us phenomenally in terms of funding and in terms of making sure that our program of research is really meeting our community needs and wider societal needs for work in this area. And so in closing, I think we're somewhere in between a turning tide and a full sea change. But I hazard a guess that in time, much like when we're reviewing grants now, we'd be pretty surprised if it didn't have a solid KT, knowledge translation section. We're required to think about sex and gender considerations fully now for our funding applications and our research. And I predict that there'll be a time where we're at that place with the inclusion of people with lived experience in research too. Thank you.
Thank you very much, Erin. In a normal environment, there would be tons of applause for this tour de force of a talk which went from innovation to science to solid mentoring information for young investigators attending the meeting, and to really brilliant ideas as to how we can start working with patients rather than doing things for them or to them. So I just want to mention very generally that for questions, participants have to go to www.sli.do, enter 80995. I think this is correct. If not, please double check through the information that you have from Margaret and submit your questions. And we have 2 questions, and those are the only 2 that we can take because of time restrictions. So the first question is about the methods used by CREST-PD, and the question is, which research methods has CREST-PD developed bespoke or substantially influenced the that you're especially proud of? What is your best or the thing that you're proud of the most? And just to let you know what's the second question, and if you could mention something about how you tailored your resources towards the need of minority populations. So the only two that we can take, and we have to be brief because yeah. Thank you very much, Erin.
Got it. And any other questions that come in, I can see them on Slido. I'll respond to by email afterwards.
You can respond yourself.
Yeah. So thanks, Rob, for that question. You know what wasn't available when we first put CREST together was a specialized engagement model for bipolar disorder. There are certain things about working with bipolar disorder that are amazing to harness in research. Creativity, engagement and visual methods, thinking outside the box. You know, the pure assets of bipolar disorder are critical and valuable for research and for engagement. And so we've published a couple of papers on the specific community engagement model that we think works for bipolar disorder. So that's one of the things that I'm particularly proud of. And to the second question, which is around curation of resources for the needs of minority, diverse LGBTQ2+ populations. It's not so much an issue of curation as it is an issue of co-design and selection of those resources. So we're in the throes of a persona development exercise that Dr. Emma Morton is leading, where we are really co-creating personas for use of our app, but co-creating them with people who face barriers and face barriers to access to care. Thank you.
Thank you very much, Erin. Please continue submitting questions for Erin for her to respond. And with that, we move to the first set of our lightning talks. Okay, Tricia.
Okay, so thank you so much, Erin, for that wonderful talk. So we are going to move into our first set of lightning talks. Tim actually introduced this format last year. It seems to be very widely popular. So this is our first time trying it, obviously, in the virtual format. So we'll see how it goes. Just for anyone who's not familiar, the lightning talk format is a means by which researchers can communicate the main results and import of their findings in a very brief and concise manner. So these are 4-minute talks. I will ask the speakers to just keep an eye on their chat because Lila will be sending you a message if you're coming close to time. And if you're going past 4 minutes, I'll just cut in. We will save questions for the end, so please submit your questions through Slido, and if you can just indicate which speaker the question is for, and then at the end I'll go through with our 5 set of speakers to address the questions that have come in for them. So Lila, do we have the first set of slides up? Perfect. So our first Lightning Talk speaker is Maria Aman, and Dr. Aman is a psychiatry resident in the UBC program, and she is supervised by Dr. Evelyn Stewart. So I'll hand it off to her.
Sorry, I am unable to see my slides. Great. So hi, my talk is titled Prevalence of PANDS in Child and Adolescent Eating Disorders. The diagnosis of PANDAS, pediatric autoimmune neuropsychiatric disorder associated with streptococcus, and PANS, pediatric acute onset neuropsychiatric syndrome, is shrouded in controversy. PANDAS is theorized to be an autoimmune response to a streptococcal infection, causing sudden OCD symptoms and/or tics. This diagnosis was later expanded, and in walks in the PANS diagnosis. This encompasses any infection that triggers sudden OCD symptoms or food restriction. These infections can include influenza, varicella, and a number of others. The PANS diagnosis here highlights the overlap between eating disorders and OCD symptoms. So far, the prevalence of PANS and PANDAS has been evaluated in pediatric patients with tic disorder, movement disorders, and OCD, but none is screened in eating disorder population. So our aim with this project was to do just that. We distributed a questionnaire to the parents of children who were referred to the BC Children's Eating Disorder Program, and we collected 112 questionnaires in total during a 21-month period. 4 were excluded because the child did not meet criteria for an eating disorder, and 8 were excluded because the questionnaire was simply incomplete. The remaining 100 questionnaires were analyzed using strict diagnostic criteria, and we found that 0 met criteria for pandas. However, 52% met criteria for PANS. The lifetime PANS rate of 52% within the pediatric eating disorder population was surprisingly high, much higher than that previously reported for OCD populations, which was 5%. We completed a retrospective chart review as well and found that those in the PANS group were more likely to be female, prescribed an SSRI, and parents reported that along with abrupt onset OCD symptoms and abrupt food restriction, their child had abrupt anxiety, depression, irritability or aggression, behavioral regression, school deterioration, and sleep problems, enuresis, and/or frequent urination. Our study shows that those with an eating disorder and meeting PANS criteria are a distinct subgroup, and further studies are needed to characterize this group in regards to functional impacts and management approaches. With my remaining few seconds, I wanted to express my thanks to everyone listening, to all the families involved in this project, my sincere gratitude to the entire research team, Jennifer, Boye, Cynthia, Shannon, and John, and to thank Dr. Evelyn Stewart for her guidance and mentorship. Thank you.
Okay, thank you so much, Maria, and I think you might get the award thus far for the most concise talk we've had. That was excellent timekeeping. So just a reminder to continue to submit questions for Dr. Aman through Slido, and we'll get to them at the end. But up next, we have Dr. Hitman, who is a clinical assistant professor and a postdoctoral fellow in the Department of Psychiatry, and she is supervised by Dr. Jehanine Austin.
Thanks so much. So I would like to thank you for this opportunity to share some of my PhD findings. And I'd like to start off by acknowledging that I'm presenting to you today from my home, which is on the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. My research question was, how do women decide whether to take antidepressants in pregnancy? And the take-home message is, it's complicated. It's important because about 10 to 15% of women experience depression during pregnancy. And we know that antidepressants can be effective in treating depression, but we also know that women face alarming media headlines that really focus on the risks associated with taking antidepressants in pregnancy. And that's only part of the picture that we know from research, which is that the risks of untreated depression in pregnancy are about equal to the risks of antidepressants in pregnancy, which is why clinical practice guidelines suggest that clinicians support women to make an informed treatment decision. However, we don't know as much about how clinicians can best do that. I looked in the literature and published this narrative review that found 11 articles that published women's perspectives on decision-making about antidepressant use in pregnancy. And the theme that arose from those publications was that women balance the risks and the benefits of antidepressant use in pregnancy. As you can see, that's a fairly surface-level finding, and so the purpose of my research was to dig more deeply into the process and develop a decision-making theory of women's decision-making about antidepressant use in pregnancy. To do that, I recruited women from specialty clinics at BC Women's and Children's Hospital and from the Reproductive Mental Health Clinic as well as the Psychiatric Genetic Counseling Clinic. And I'd like to thank my colleagues in the Department of Psychiatry who work in both of those clinics who helped out with recruitment, as well as I recruited from the community. And I did interviews with 31 women that were either in person or by phone. They were digitally recorded and transcribed verbatim. For the analysis, I used constructivist grounded theory within a feminist theoretical framework. And in the interest of time, I won't say more about that method, but I'd be happy to answer any questions about it. As you can see here, the decision-making process was really complex and dynamic. There were no discrete stages or phases. There were many layers of decision-making from the context, from the societal context all the way up to the emotional context that women experienced. And there were three really predominant emotions: guilt, anxiety, and fear that influenced the decision-making process. Women moved back and forth between three clusters of decision-making activities: seeking information, making sense of information, and self-soothing as they reached towards a decision. I'd just like to highlight one thing at the moment is that the pressure that women were under at this time. There was the stigma from mental illness, the stigma of taking antidepressants even outside the context of pregnancy, and then the societal expectations of women in pregnancy, which include not taking any medications in pregnancy. And these compound at a time that's really vulnerable for women. So I presented to you today just a brief snapshot of the first rigorous decision-making theory for antidepressant use in pregnancy. Look out for the publication that's hopefully coming soon. And thank you so much for your attention and to everyone who helped make this research possible.
Okay, thank you so much, Dr. Hittman, for that excellent presentation. Just again, a reminder, keep submitting your questions through Slido. And we shall go on to the next presentation. This is Dr. Emma Morton, who, as Dr. Mihalik mentioned, is a postdoctoral fellow and a Marshall Scholar and a member of the CREST-PD network, who is supervised by Dr. Mihalik.
Thank you so much. Good morning, everyone. I'm going to present the results of a Canadian biomarker integration and depression study on the quality of life impacts of 2 treatment strategies for major depressive disorder. So what is quality of life? If you look on Google Images, it would have you believe that quality of life is running through a field with your arms outstretched, doing yoga by the beach, laughing at a bowl of salad, any of these ridiculous things that really do form part of our everyday lives. But for people with major depression, which is about 5% of Canadians each year, it might actually be the single most important factor which tells them whether or not their treatment worked for them. Because when people seek treatment for depression, they want their relationships to improve. They want to feel productive and fulfilled at work and to be physically well and healthy. So more than just not depressed, people want to feel happy and satisfied with their lives. Medication can improve depressive symptoms and quality of life, which is naturally a related outcome. But unfortunately, up to 2/3 of people don't respond to the first antidepressant they're treated with, in which case an alternative strategy is prescribed. Understanding how that impacts quality of life can help clinicians pick between treatment strategies. I analysed data from a 16-week trial of 179 Canadian patients with major depressive disorder to describe how quality of life changed for those who responded to an initial course of antidepressants, escitalopram in this case, and those who did not show symptom reduction and were then prescribed an adjunctive antipsychotic, in this case aripiprazole. Both treatment strategies showed efficacy for improving quality of life. The people who had a clinically meaningful decrease in depressive symptoms with antidepressant treatment, unsurprisingly, also had improved quality of life in the first 8 weeks, which then leveled off. And as you may expect, antidepressant non-responders showed a much smaller quality of life improvement in phase 1, but with the addition of aripiprazole, experienced large improvements in that next 8 weeks of treatment. Secondly, I looked at the proportion of patients and their quality of life relative to community norms. And you can see at baseline, no participants had quality of life that was similar to the general population. This did improve for both arms over time, but even though quality of life improved with the addition of aripiprazole, the majority of antidepressant non-responders still experienced severely impaired quality of life. Even when we look at just the patients who are in symptomatic remission, across both treatment arms, 45% of patients who achieved remission at the trial end had persisting quality of life impairments. Overall, what does this tell us about quality of life in depression treatment? The good news story is that current treatment strategies are working to improve patient-valued outcomes, but it does also tell us that remission defined on the basis of depressive symptoms alone may not give a full picture of how someone's doing. So clinical trials like CANBIND should continue to evaluate these patient-valued outcomes so that we can identify what treatments work best, not just at improving symptoms, but restoring overall satisfaction with life. Thank you.
Okay, thank you very much, Dr. Morton, for that very sort of comprehensive analysis. And next we have Dr. John Jose Nunez, who is a fourth-year psychiatry resident in the research track and a master's student in computer science, who is supervised by Dr. Raymond Lamb.
John Jose, we can't hear you at the moment.
John Jose, we still can't hear you. No, we are still not able to hear you.
Any luck? Oh, I think it's working now.
Now you're good.
Hear me?
Yeah, we can.
It's showing that it's working on my end. Can anyone let me know?
Yes, we can hear you now. You're
okay, I'm good. So sorry. Yeah, ironic that the AI project is the presenter is one of the technical problems. So sorry about that. Okay, let's jump in. So hello everyone. Sorry about that again. Thank you so much for the opportunity to come back and talk about my the final results from my project, predicting antidepressant outcomes using some machine learning. So if we could go to the next slide. Awesome, thank you. Yeah, so the motivation for this project is we know that antidepressants work well. But we also know that not everybody's going to respond or get better. And machine learning is kind of a cool way that might be able to help us know who will get better or who won't. So to quickly go over machine learning, it's a way to get computers or machines to do tasks without explicit instructions. So an example of an explicit instruction is, let's say you're watching Netflix and you press the play button. A programmer is explicitly programmed if, button press equals true or whatever, play the show that you're watching. That's kind of boring. We know how to do that easily. But if you think about the bar on Netflix that shows you may like, no one's actually explicitly programmed that. Nobody's like sitting at Netflix headquarters being like, oh, John Jose, you're a big nerd. I'll show you some Star Wars. Instead, they use machine learning algorithms to learn this without explicit instructions. In this case, they take as input data what shows I've watched in the past and liked, and then train some algorithms, use that data to then predict what shows I might like in the future. So luckily, we could use similar algorithms to predict antidepressant outcomes and other kind of cool things in clinical medicine. For instance, by taking data from a clinical trial where we've seen whether patients get better or not, using the machine learning algorithms and then predicting whether patients in the future will get better or not. So we could go to the next slide and then talk about what we did for this project. So our predictions are based on clinical data, so no neuroimaging or blood tests, things like that. We use clinical data like demographic information or your scores on the antidepressant scale and whatnot. And the first step of the project was to do a replication of some prior work. So that was using data from STAR-D at the trial back in the 2000s. We trained the machine learning algorithms based on like 80% of the data from STAR-D, and then use those algorithms, the models, to then predict whether the other 20% will get better or not, and you see what sort of accuracy you get. And the next step of the project was then to do an external validation. And that's kind of what's required to know whether these things will actually work in the real world, will actually work with real patients. What you do is you train on one data set, and then you test those models on a completely independent data set. So in this case, we trained on STAR-D and then tested on the Canbine-1 data set from Canbine, which is a Canadian study, depression study that folks in our department are involved with, and is completely different from STAR-D. So you're then maybe wondering what the results were like, so we can go on to the next slide. So the first part, the replication was a success. That's not really quite as trivial as I think, given the kind of replication trouble in science. But we even beat their performance a little bit, which is either because they did a good job or probably more likely because of a bunch of other factors that have to talk about it. Or the next big result, kind of the most interesting, was the result of the external validation. And again, so it's training on STAR-D, then evaluating on Canbine. And it actually depended on which outcome we were looking at. So one of the things we looked at was remission, kind of getting completely better from your depression, or almost completely better. And that actually went really well. The prediction performance is really good, similar to when we did just using the STAR-D data. But when we predict antidepressant response, so that's getting 50% reduction in your symptoms, the accuracy actually went down a lot. And this was interesting because prior work hasn't really seen this as much. They see kind of similar results for external validation results always go down for any outcome. So this is kind of neat. I'm happy to talk more about these if you have any questions about those results. And then lastly, this is kind of more of a kind of CS detailed one, but using less data actually helped their performance in some ways, which is also kind of interesting. And that's that. Thank you so much. Sorry again about the technical problems, and thank you to Dr. Lam and the other supervisors on this project and the funding groups and the greater Canbine team. Thank you so much.
Thank you so much, Dr. Nunez, for that very timely and excellent talk. And our next speaker is our next and last speaker, I should say, is Dr. Melissa Woodward, who is a postdoctoral fellow supervised by Dr. Bill Honer.
Hi, everyone. Thank you for listening. I assume everyone can hear me. So schizophrenia is a chronic psychiatric disorder characterized by the presence of psychosis and typically accompanied by significant social and occupational dysfunction, as well as significant cognitive deficits. And this is a painting done by Brian Sharnley, who is a British artist who experienced schizophrenia. And so he painted this series of bondage heads paintings demonstrating his experience living with schizophrenia and the side effects of his antipsychotic medication. And so neuroanatomic differences can be observed at early stages of illness, including reductions in medial temporal regions, like the entorhinal fusiform and parahippocampal cortices that are indicated here. Reductions in these regions have been associated with increased symptom severity, and these regions play critical roles in cognitive processes like episodic memory and facial and emotional recognition, processes that can be impaired for individuals with schizophrenia. Individuals with schizophrenia are at elevated risk for cardiovascular and metabolic dysfunction, including high rates of obesity and diabetes, due to a number of factors, including the adverse effects of their antipsychotic medication, shared genetic risk factors, and a variety of lifestyle factors. And so these cardiovascular deficits are actually the #1 cause of premature mortality for individuals with schizophrenia, resulting in approximately 10 to 20 years of premature mortality. Exercise interventions may be helpful in addressing these cardiovascular concerns, as well as promoting neuroplasticity and clinical improvements. These changes are thought to occur through the upregulation of brain growth factors like BDNF or VEGF, triggering neuroplasticity within the brain, primarily within the hippocampus. Results so far have demonstrated hippocampal neuroplasticity in response to exercise for participants, primarily focused on studies looking at men with chronic schizophrenia. However, the capacity for neuroplastic change in cortical regions beyond the hippocampus remains equivocal, and questions remain about the ability for exercise interventions to benefit women and participants at earlier stages of illness, which may be a critical point of intervention for preventing further loss of brain and clinical deterioration. Women with early psychosis living in Hong Kong were randomized into either an aerobic exercise, yoga, or waitlist groups. Medications were maintained over the course of the intervention. They participated in 12 weeks of exercise, exercising 3 times per week at moderate intensity. Clinical assessments and structural MRI scans were completed before and after the 12 weeks. Healthy volunteers were also recruited and age-matched with our group, and they completed baseline assessments only. So no baseline differences were observed between our participants with early psychosis and healthy volunteers or between our exercise groups. However, at 12 weeks following the exercise program, the aerobic group exhibited a greater increase in fusiform cortical thickness compared to the participants in the yoga and the waitlist group. We saw a similar increase in intrarhinal cortical thickness for the aerobic group. However, this didn't survive a 2P correction for multiple comparisons. Participants in the aerobic group also demonstrated a decrease in their body mass index, and they demonstrated a decrease in symptom severity. And this decrease in symptom severity was associated with an increase in cortical thickness for both the intrarhinal and fusiform cortices. So this is the first study to assess the impact of an exercise intervention for women with early psychosis, highlighting the potential for early interventions for individuals with psychosis to address neuroanatomic, clinical, and physical health concerns. Work by Joe Firth and his colleagues have found that autonomy and social support are key factors to engage participants in exercise interventions for individuals with psychosis. So when designing exercise programs for patients, allowing them choices, whether it be in the choice of music they listen to or the exercise modality, an elliptical versus a seated bike, and providing enthusiastic support for exercise trainers and in group exercise settings can be helpful to promote adherence to an exercise program that can be highly beneficial. So thank you for watching, and I'd like to acknowledge the study participants and the staff at the Hong Kong Psychosis Clinics, as well as my collaborators and my funding through the Marshall Program. Thank you.
Thank you, Dr. Woodward, for that excellent talk. Maintaining physical health for our patients is obviously very, very important. So that was fantastic to see that work. So maybe what we'll do is we're still waiting for some additional questions to come in. So please do submit questions for the speakers. But as we have a bit of time, maybe what we'll do while we're waiting is I had some questions for the speakers that we can go through, and then we can run to the audience questions. So for Dr. Aman, I was just wondering if there are any known sort of treatment implications for treating patients with eating disorders who have this type of PANS-like presentation. Like, is it known that certain anti-inflammatories work well for this subgroup, or a certain class of medications goes well for this subgroup?
Hi, yes, great question. There was a recent paper published earlier this year about studying response to anti-inflammatories and NSAIDs in particular. So there's some mounting data to say that those with PANS with this abrupt OCD picture may respond well to anti-inflammatories, but still quite unexplored in terms of treatment options.
Thank you. And we have a question for Dr. Nunez. What is the advantage of machine learning develop sample test sample over the traditional logistic regression develop sample test sample method?
That is an excellent question. Okay, it's turning green, so I hope people can hear me this time. Yeah, there's a lot of hype about machine learning, but a lot of the techniques are just based on simple logistic regression with some kind of tweaks that you can do to kind of make the performance better. But there definitely are a lot of similarities. For instance, some of the results we did regularized logistic regression, another one called elastic net, which is another type. So there definitely are some similarities with it. There are, of course, other non-logistic regression-based techniques. The best performing technique in our project was something called random forests, which uses something called decision trees. There's also neural networks. But yeah, a lot of it's just logistic regression. So.
And while we have you here, there's a second question for you. First of all, comment that your talk was very clear. And how does the baseline of spontaneous remission figure in with machine learning approaches to treatment efficacy?
Yeah, that's a really great question. So when we train the models, we don't know whether people would have just got better without the medication, placebo, just the baseline improvement, or not. We're just predicting whether people will get better if they're taking the medication. So the cool thing is that means that the machine learning model has to predict essentially both, whether you'll respond because of placebo or just naturally, or respond from the intervention. So that's how it factors in. It needs to do both. The methods that, the more advanced methods, the kind of the really modern stuff like neural networks, kind of have even more advanced ways to predict, to maybe explicitly predict, like, oh, you're somebody who would naturally get better, baseline get better, or you are somebody who will get better from medication. But you need lots of data to use those models. The ones we're using are usually quite as fancy, but at the end of the day, yeah, it's all the same prediction. And there's also things like if your depression is less severe, there's a better chance you're going to remit. And the machine learning model definitely picks that up. It'll kind of figure out that if you have a lower score at the beginning, there's a good chance you're going to get better, which, yeah, is kind of obvious. But.
Great, thank you. And a few questions for Dr. Woodward. The first one was that the 1% increase that you reported in your findings, is there any sense in the literature yet of what percentage of gray matter volume increase starts to become clinically significant as opposed to statistically significant?
Yeah, this is a great question, and sorry I can't start my video, but that's okay. I can answer the question anyway. I think this is really the area of research that needs to be the next step of this work. Oh, there we go. There we go. So unfortunately, the answer is that I'm not quite sure. And so there are some, starting to look into increases in clinical symptoms in conjunction with gray matter changes might start to answer some of those questions. But at this point, we really don't know. And so I think that that's definitely a really interesting area for research and trying to understand what neuroanatomic changes mean for individuals. Is really an important question. So I don't know is the short answer to that.
And the second question is whether you think or whether you have data to suggest whether the effect of exercise is reversible.
Yeah, again, this is really an important next step. So a lot of the research in exercise interventions focuses on these short time periods of 12 weeks or sometimes up to 3 months, but kind of the long-term effects of an exercise program, whether it's maintained or whether it's stopped, aren't really known. There is some work that was done actually with this population, so they were followed up with about 3 months after ending the exercise program, and there was some evidence that their clinical symptoms remained improved, and as well as some of the cognitive benefits stayed around, but it's not, we haven't yet been able to look at whether their neuroanatomic changes were present, but it does seem like perhaps very preliminarily there might be some evidence for some ongoing cognitive benefits. As for reversible, if that was the desired outcome, I'm not so sure that that was the way to go. But generally, fortunately, exercise is a great thing, so we're not trying to reverse those effects.
Great, thank you. And I actually had a question for Dr. Morton. It's just something that I feel like I've never gotten a clear grip on, is if you could comment on how quality of life, functioning, and symptoms are different constructs and how they might correlate with each other.
Sure. So that's the kind of big million-dollar question, I think, that we're trying to add to the literature on. The studies which are available suggest that up to about 50% of the variance in quality of life is explained by depression, and something smaller like 15% is explained by functioning. So they're obviously related constructs, because when your mood lifts, the way that you feel about your life might change. But we also have some evidence to say that quality of life is a lot slower to shift, so it takes longer for those improvements to emerge, and that different domains might be impacted in different ways. So things like your psychological quality of life, your sense of satisfaction and well-being is obviously much more closely tied to depression and quicker to change than things like your social relationships, which if you have been depressed for a long period and not seeing friends and family and becoming more distant, might take more time to shift. So it's a really interesting area, and it goes much much further than the idea that quality of life and depression are two sides of the same coin.
Thank you. And a question for Dr. Hittman. I know you mentioned you didn't have a lot of time to go into the constructivist theory that you used as sort of your framework, but I was wondering if you could spend maybe like a minute more just explaining that framework a bit more.
Yeah, for sure. Thank you. So the grounded theory methodology uses, you go through and review all the transcripts for familiarity, and then after that it is a process of identifying key significant kinds of ideas, and then you're going back and forth and connecting those in ways that are, you think, might be theoretically linked, and then kind of testing those ideas in the rest of the data set. And then gradually building those up into themes, and then connecting them further into higher level constructs, and as you build that model. And the constructivist nature of it, there's so you can have grounded theory, you can operationalize grounded theory in a constructivist frame, or in I'm blanking on the alternative word, the other framework, but anyway, the constructivist one is focused on making meaning of the experiences, and doesn't believe that there's sort of one truth that, positivist is the other option, or post-positivist, and so you're not trying to unearth kind of one reality, but rather trying to understand the complexity of the different realities and what's common between those realities.
Thank you very much for that very approachable explanation to something I was not familiar with at all. So one question for Dr. Morton. What was the rationale for investigating quality of life with aripiprazole as an augmentation agent versus another agent?
So in this case, the CanBind study was specifically looking at predictors of outcomes, both clinical and quality of life and functioning under those treatments. There's really not a lot about how quality of life changes in response to aripiprazole. So we have some more evidence to support how it might improve clinical symptoms, but the studies which have investigated that so far haven't looked at quality of life, and there's been mixed evidence in general about that kind of second-line treatment strategy. So it's an incremental step to adding to that body of literature.
Thank you. And I think we have time for one last question for Dr. Nunez. Is there any plan to test the machine learning approach to antidepressant choice against clinician choices?
I would love to do that. That is like such a great way and something I always think about. Because, you know, there's always like the question of what cutoff do we need? What performance level do we need? Right now, and I should also say, the performance is not good enough. Right now, it's like in the 70s, like the mid-70s for balanced accuracy. So I don't think we need a study to show that that's not good enough for clinical application. I don't think any doctor would use it. But yeah, getting actual clinicians to try, I think would be super cool and a super great idea. And there might also be prior work in it. I haven't ever came across it, but doesn't mean it's not out there. But yeah, I mean, it would be interesting too, because like, how would you make it fair? For instance, would you just give the data? Would you just give the person like, okay, here's a spreadsheet of like, you know, 480 different numbers with their headings for what type of data it is. Give that to both? Because if you do, you know, I would be curious there. I think the machine would probably have no problem winning, perhaps. But if you know, let the human kind of see a clinical situation and like a video of the person interacts and stuff, then I bet they could do pretty well, plus the data. So yeah, I think you have to think about how to actually do that study, but it would be super neat for sure. I'd love to see it. Yeah.
Thank you so much. So a huge thank you to all of our presenters. It's always very inspiring to see the breadth of excellent work that's being done by our talented trainees. And at this time, I did want to mention that two of our trainees that presented today, their work at UBC was made possible through a 2019 Marshall Fellows Scholarship. So Emma Morton and Melissa Woodward received this fellowship last year. And we just wanted to acknowledge and thank Mr. Stuart Marshall and Ms. Sunny Marshall for their support of the IMH Marshall program and allowing us to attract and retain such excellent trainees to our program. So I think we'll be heading into our break. A reminder that voting for the lightning talks will start at 10:45, so make sure that you vote for the lightning talk that you found particularly outstanding in this first set. And again, as Margaret said in the chat, if you do have any additional questions, you can feel free to put your name and contact information into the Slido question submission, or you can email Margaret the questions you have and she'll forward them on to the presenter. So I think then we will head into our break. So we will resume at 10:45 with our second set of lightning talks.